Okay, we're back, and this is definitely about what you need to do to take care of the flu or COVID or RSV. This will be your viral respiratory first aid kit. We're going to go deep so you understand on two levels. What are your predispositions? Things that everybody should know about themselves, things that actually are empirical, meaning they're number oriented, have to do with labs that you can understand that will remove these vulnerabilities, predispositions. And then what happens when you get exposed and you feel yourself coming down with something? What are you going to do? We'll talk about that too. All right? Long story, short story, we'll get to the end. Let's get to it. So do you live in fear of getting the flu or COVID or RSV? I hope not, and I don't think you need to be. And this is not meant to be fearful, but a lot of people are. We've just been through the pandemic, and we all know, probably in our case, we know 5 people that have died, both close and less close to our sphere of influence in our family and outside of our family. So here's what you need to understand how to deal with it, okay? So what you need to have on hand to protect yourself during the flu season and why. What you need to do now. This was part 1, how everyone is sick with the flu right now. Go back and look at that because that's all about the data of where we actually are, the context for 2024, winter of 2024 going into the spring of 2024, okay? Viral respiratory trifecta. All right, so having the appropriate supplement on hand will make a world of difference to you. There's no doubt about that. We'll go through that. That won't be a mystery. When you come down with any or all of these respiratory viruses, and one of the unique things about this year is people have actually come down with all 3 viral respiratory infections concurrently. And that has been the problem. Not that any one was so powerful, it was the collection of always getting exposed to one after the other after the other. I won't say it's never happened before, but it's never been thoroughly documented as it's been this year before. So here's what you need for your viral respiratory first aid kit. What you'll learn in this video is why most people are at risk, or who are the most at risk for their severe symptoms, are those with the worst predispositions. What are those predispositions? How to address them easily, and when to do so. How to protect yourself when you do get a respiratory virus, get exposed to one, and feel you're coming down with one, onset, by having a well-stocked viral respiratory first aid kit. Why no aspirin with onset of symptoms is absolutely necessary. No aspirin. What you should have in your viral respiratory first aid kit. Here it is, and it's full, and we're going to end up back at this slide. So I'm going to show it to you for the people who just stay on 30 seconds. There you go, you got it. But I'm going to break it down and tell you why certain things are more important than the others. Okay, so stay tuned. This is going to be long, hate to say it, but it's also going to be thorough. This is going to be something you won't have to listen to year after year, or you should listen to it year after year because the situation won't change. Your respiratory viral first aid kit has 2 parts. One is addressing your specific predispositions. So specific to you and specific to me. We don't have the same ones. So it's not a one-size-fits-all. So break that concept. And also addressing your symptoms as you do come down with them, should you do, after you're exposed. A brief review to set the context. How does COVID-19, which we've just been through, all of us, I'm speaking from North America, fit into all of this? SARS-CoV-2 virus interferes by, and this is very new conceptually, this is a paradigm breakage, and it's from a couple of previous videos. Your virus, COVID-19, SARS-CoV-2, reduces SAM levels, S-adenylmethionine. It's one of your methylating factors, by using up these methyl groups for viral replication. So let me give you a little paraphrasing here. You have a thing called methylation, which I spent a lot of videos on, so I'm not going to go too much into that, but we'll go into a little bit here. And it is a method that has to do with a lot of nutrients. In the end, I call it a glutathione factory because it makes glutathione in the end. It makes SAMe on the way to making glutathione, and it makes a number of other things. This apparatus, which turns genes on and off, that's what we call it, methylating or non-methylating, is actually taken over by your virus. Your virus comes into you and says, can I borrow this apparatus for a second? I'll give it back when you're really sick. And what happens is you actually need your methylating to make the glutathione and other things to protect yourself. And suddenly you don't have this apparatus. You don't have the ability to do that, or it's very decreased. And yet your virus has taken over and now is using it very efficiently. So you have 2 problems. One, you can't use what you ordinarily had to make glutathione and other things that would protect you. And other, it's making your virus stronger. So by reducing SAM levels, using up methyl groups of viral replication, by simultaneously increasing demand for methyl groups, glutathione in particular, and depleting the supply of methyl groups. It is huge. So this comes out of a study, human genetic determinants of viral diseases, human genetic determinants of viral diseases. That was never conceived of before. It was always in terms of the virus. It's a strong virus. This variant is very strong virus, very deadly virus, very infectious, very contagious. Those are the words always about the virus, always about the pathogen, never about the person, never about the landscape, the terrain, the terroir, if you will, if you like wines. So can a person have a predisposition for getting a respiratory virus? The answer is yes, but I'm going to fill in some of those details. There's a huge concept for this. So ultimately, COVID-19 wreaks havoc with the body's methylation metabolism pathways, ultimately leading to imbalance of folate, B12, homocysteine levels. You can say glutathione, of course, too, SAMe levels, I just stated. Altered amounts of these nutrients influence how a person reacts to an infection. In other words, how vulnerable they will be. That's huge. That came out in 2017. Amazing, just before COVID. 4 years later, from the COVID studies yearbook that I put together, COVID-19, a methyl group assault, attack on our methylation. It says the same thing that just happened 4 years ago. Now we're in the middle of the pandemic. This is a Swedish English UK study. COVID-19, a methyl group assault. And so here's my real skeleton sketch of methylation. Methionine cycle, folate cycle, transsulfuration. Fancy words, you don't need to know any of them. But what you do need to know is that you need to have this working well for you in order for you to make glutathione. That's why I call it a glutathione factory. There's a lot of steps along the way, and there's a lot of mutations, some more famous mutations for working poorly that make the bigger problems. So there's a lot of possibilities for error or decrease effectiveness, but there's some that are more commonly defective that we'll talk about. So you have SAMe there, you have methionine synthesis, B12, homocysteine. You can go on and all these. You don't need to know all this, but know this one over here. We're going to talk about it in a second. MTHFR, methyl tetrahydrofolate reductase, who cares? But SAMe affects this, one thing, and also people have a mutation for it. Let's get to it. So basically, this glutathione factory comes out of methylation. That's the bottom line, and it's decreased. It's the #1 antioxidant in your body, and oops, it's not available anymore because the virus has hijacked the methylation. Isn't that amazing? That's a new concept, just not even a half decade old. So the correlation between MTHFR, which I just showed you, and they number the mutation C677T, allele frequency. By the way, I have that, homozygous. My wife has that, homozygous, so it's not that rare. And actually, it was an evolutionary milestone. I'll tell you that in a second. Talked about it in previous videos. So that MTHFR C677T allele frequency and coronavirus mortality was found very high at 85%. I mean, 85% of the people, and this is an Italian study, that died, that they studied, had that mutation. Holy cow! Holy cow! So we're seeing a genetic predisposition to being very vulnerable to these viruses. Okay, so the correlation between homocysteine level and COVID-19 severity of infection has demonstrated that homocysteine over 16, that's micromoles per liter if you care, correlates with severe prognosis or mortality, i.e. death. And when in the hospital, so what I did is I simply went back and looked at my spreadsheet of numbers of clients that I've seen. I said, I wonder if any of my clients have homocysteine levels of that level. And sure enough, these are not acute people in the hospital, and they had levels already over what this article talked about. So if they went into the hospital or if they were exposed, they would do very poorly. You can bet. Bet money on at least these three people, if not this whole line over here. So homozygous carriers, like myself and my wife, of this variant show higher homocysteine levels than normal when attacked by, when in possession of, when exposed to any of these viruses. Here they're talking about COVID-19, of course. So COVID-19 spreading across the world correlates with C677T allele of MTHFR gene prevalence in 2021. That's the name of the study. I kid you not. Punch that into Google and you can read all about it. So what you need to know, there are two groups of people that will have low glutathione. One, I sort of gave you a little bit of a vignette about how they came to have low glutathione, right? The other is a group you probably have already heard of. So this group can change their status and therefore limit their or reduce their vulnerability to any of those viruses. And those are the insulin-resistant people. They have decreased amount of glutathione and decreased ability to generate glutathione. This group over here, which is what I've told you about, any of those with genomic mutations, not just MTHFR, but a lot of those others, methylating factor mutations. They have a decreased ability to generate glutathione, which is what you need. Point one, some people are much more vulnerable than others. Repeat that to yourself. Some people are much more vulnerable than others. We are not one size fits all. Please don't fall into that. If I all take this, we'll all be good. That is a fantasy you've been sold by whoever you wanted to buy it from. Due to genomic mutations, SNPs, single nuclear polymorphism, SNPs, we'll just call them SNPs. We are definitely not all the same. Point number two, some people are much more vulnerable than others. Where'd you hear that before? Due to insulin resistance. I'm trying to sear that into your memory. Two groups. So the most vulnerable to respiratory viruses are those who have both groups. That's kind of a no-brainer, right? Those who have both groups. The flu, RSV, COVID, insulin resistance, and whatever genomic mutations, not just MTHFR, have a reduced ability to generate glutathione and others. This limits their ability to methylate. To methylate is to turn genes on and off, by the way. That's one of the main functions. All right, so why specific supplements are going to be recommended? I am going to give you an explanation through labs. You probably have never seen this before, and you'll probably get real tired of listening to it by the end of this video. But I think it gives you a different way to appreciate what I'm talking about. I'm not just saying, hey, buy this supplement. No, let's use our brains a little bit and let's get a context. And I think I've been lucky enough to do some fairly extensive labs over a number of patients that now I can put them together in a spreadsheet and do scatter plots and say, wow, I didn't know that. And I didn't. I'll share you these aha moments with you, okay? So here's how I work. So we start with clients have come in, they all get their labs. All the labs go on a progressively growing spreadsheet, bigger and bigger and bigger. And from the spreadsheets, I've learned to do scatter plots. That is, you can do usually just two variables. Sometimes you're lucky enough you can do a number of variables if they have a similar width or height of range. In other words, if there are 100 points from high to low in a range, you can compare them. But if one's like 1 to 5 and the other's 1 to 100, you can't compare those. Not that you need to know that, but that's what I do. So then I come up with the scatter plots, and the scatter plots is what we're going to be talking about. So what you can't manage, you can't measure. I'm hoping you've heard that before. That's by Peter Drucker, and he was a very precise engineer, and he was known for a number of quotes, but this is the one he's probably most known for. It's like, in order to know what you're talking about, it's got to be measurable in some way. So there's got to be a metric involved. So my metric is labs, of course, and research. But when you just rely on research, research is not adequate enough. You don't know the propaganda behind that. You don't know who's sponsoring it. You read it, and if you can match it with your own experience, you go, I believe that. But if it's just, oh, I read this study, that doesn't mean anything. But what you need to know first, every lab result was divided into two groups of people. Everyone's results, I'm speaking of my results, right, of all that big spreadsheet. And I put them into their either insulin resistant, means they have a HOMA-IR of over 1.4, or they are not insulin resistant. They have a HOMA-IR. And I'll show you what that is in a second, under 1.4. That's it. It's either left or right. So HOMA-IR over 1.4, their labs, they're insulin resistant people. So we're just going to call them IR people. And then you have HOMA-IR under 1.4. Those are labs from non-insulin resistant people. And they're going to be called non-IR, right? Groups, left and right. Everything is going to be left or right. There's no middle ground here. Okay, so HOMA-IR, what is that? Really, in the last 20 years, this has been used and has become kind of the standard. So when you talk about insulin resistance, it's an empirical number. It's not like, I'm feeling a little insulin resistant today. No, it's like, it's a blood work result. And it has to do with fasting glucose and fasting insulin. That's all you need. And if you're in the United States, which we have not learned to go metric yet, so we have our own little system. So that's our formula here. And for the rest of the world, Canada, Europe, Mexico, South America, Africa, they can use the metric system. But it's said slightly different formulas, but it comes up with the same thing. Over 1.4 is all you need to know. Two different formulas depending where you live. And this is where you can go online. It's a link. It's totally free. You plug in your fasting insulin and fasting glucose. And depending where you are, you just toggle that to your metric. So to American or non-American. What does that cost you in the United States? LabCorp is $14 plus a blood draw fee, so about $25 we'll call it. And in Quest, it's about, we'll say that's about $35. And there's a link, you can do it for yourself and it's free. You basically pay for it and you find out where in your area you need to go. Sometimes it's 5 minutes away if you live in a semi-urban area. Others, you might have to drive a little farther, okay? Great way. And I'm encouraging you, which is the gist of everything I do, pretty much in every video I do, is that you learn about yourself. Don't go, my doctor said I really could care. I hope you have a good doctor. I hope you're respectful of each other and you have a good conversation. You need to participate and take action on yourself. In life, the reality is there are only two groups of people, metabolically speaking, of course. There are IR people and non-IR people. That's it. That's true. So if you go down the street, there are IRs and the non-IRs, right? And you can go up and ask. Most people don't know what their IR is, but they should. They absolutely should. This is what insulin resistance looks like when you put on a continual glucose monitor. Why would you do that? I do this with my clients. This is for two reasons. One is I get to see how well they can control their glucose, and that's what insulin resistance is how well you can control your glucose. Some very poorly, so I can tell. I can visually tell. For 14 days, they put this on, so I get a pretty good idea of what they are at night, what they are during the day, before and after they ate. And of course, I look at their diet as well. They document that. But the point here is insulin resistance is a real thing. Insulin resistance is about how much glucose is in your blood at any given moment, and that usually has to do with your ability to control it. Pretty interesting though, right? So why you need to know what happens as you get sick and why your predisposition usually determines your experience and outcome when you get sick. My sort of layman's way of saying this is what happens when you get sick, how you experience it. Respiratory virus you get exposed to, you get some inflammation, maybe a little runny nose and so on. Then it gets a little worse. Perhaps a fever is starting to happen here. But what happens is as your virus has been exposed, it starts replicating. If you can't control it, your glucagon goes up, forces your liver to make more glucose. Your glucose goes up. Your electrolytes shift, and you start to feel pretty lousy. So whether it takes a couple days for you to get over it or you don't get over it, who's most at risk for the worst outcomes of the viral respiratory trifecta? That's really what we're talking about, right? Not insulin resistance. This is a graph here, right? Non-insulin resistance versus insulin resistance. Those who have the methylation mutations, those SNPs. So we have over 1.4 and SNPs, you can bet they are the most vulnerable. Here they are, insulin resistance, and they have the SNPs, most vulnerable. They don't have the SNPs, and they're not insulin resistant. They're the least vulnerable. Those who are most glutathione deficient have the worst outcomes. Glutathione deficiency is the ultimate driver of how you respond to a virus, a respiratory virus. What you can do to address these two predispositions, insulin resistance greater than 1.4, that leads to glutathione deficiency, and whatever SNPs that you may have, methylation SNPs you may have, lead to glutathione deficiency. Starting the context with lab results, beginning with homocysteine, since we already heard about that, right? Here's what we know. Here is HOMA-IR in the bottom, from 0 to 1.4, so they're all non-insulin resistant, and over that, and they're all insulin resistant. What do we find? What we find is, as your HOMA-IR increases, even within the non-insulin resistant side of things, your homocysteine increases almost automatically. So where do I get that? These are, again, the clients that have come into me, and I have this big spreadsheet. I go, how do these correlate with each other? That makes perfect sense. That correlates with research that's already out there. So I like it when my data has a strong reflection of what we hear about. It just validates for me. I don't believe all research for various reasons. So glutathione. All right, you won't believe what a dramatic difference glutathione can make for insulin-resistant people. Example, liver enzymes. So these are common liver enzymes, AST and ALT. ALT, when it's high, it's usually indicative of fatty liver. Lactose dehydrogenase and GGT, both are about pretty severe liver disease, whether it's cirrhosis or advanced non-alcoholic or alcoholic fatty liver disease or some other. So these are very bad, and they seldom rise until it's bad. These rise more commonly, and this is more, you can measure all sorts of degrees of fatty liver. So what I did here is, you notice you have dots and you have solid lines, but they're the same color. Well, the blue of either is AST, the green of either is ALT, but what we find is the non-insulin resistant people, as we measure those with higher and higher levels of glutathione, the non-insulin resistant people, it's increasing glutathione really doesn't matter, didn't change anything. But with non-insulin resistant people, the higher their glutathione was. So they're insulin resistant, but they had high enough glutathione and they weren't taking it as a supplement. It's really too new. Most people don't know about that. As their glutathione was higher, their liver enzymes were lower. So both for these two liver enzymes, and there again, say these two liver enzymes and glutathione as well. Notice the dotted lines here is just like over here. The dotted lines of insulin-resistant people decreased. So these dangerous liver enzymes decreased as the glutathione became higher. Isn't that profound? Whereas it made really no difference at all for the non-insulin resistant people. Same chart as before. There's the glutathione, ALT, AST. But what I did is, now I compared it to age. Look at this. Same two, I took all the people in there and I go, all right, let's just do these two liver enzymes versus how old they get. As they get older, our liver enzymes tend to rise. You know, we decrease, we have less and less glutathione. So it is a kind of a cause and effect, but there's other factors. Nothing's ever one-to-one, but this is pretty straightforward. But it's almost like I put a mirror between the two and said, wow, everything that is improved with glutathione, as you get older, everything that gets worse as you get older gets better when you add glutathione. And that's in essence what this shows. So look here, compared to age, we find that those same two liver enzymes that are, so here we go, so age, the older you get, the higher those liver enzymes. Here we go, the more glutathione, the lower those liver enzymes. It doesn't make that much of a difference for the non-insulin resistant people as they get older. As they get older, those liver enzymes also increase, but very little, but it also makes a difference for them as well. As we become sick with a respiratory virus, our CRP, C-reactive protein, increases. It's a marker, a biomarker for inflammation. But what happens next depends completely, totally, inherently on our insulin resistance status. Our insulin resistance status, HOMA-IR, the HOMA-IR number, here we go. I put glucose to inflammation. Remember I said as you start to get exposed, you start to get sick, you feel the inflammation, glucagon rises, glucose rises, electrolytes get off by a little bit, and you're feeling pretty achy. Well, what happens is as your inflammation, and you want under 1 is healthy. Anything over that, you have a problem. So when you're way up here by 9s, that's pretty high. So what happens here is for insulin resistant people, it gets high, glucose is higher and higher and higher, and with their inflammation, and then it comes down. But over here is dangerously high, so the medication kicked in and various things. Over here, for non-insulin resistant people, it's pretty much a straight line. You know, they stay well within the normal range for the whole time. It dips a little bit and rises. I'm sure in a year or two when I have more data, it will look a little bit different, but not much. It'll probably be more of a straighter line, but it really doesn't move much is the point. Now let's look at glucagon and insulin. Now that you've already heard about that, of course, and inflammation a little more deeply. Okay, so the difference is in their glucagon to increasing inflammation. So you have insulin resistant people, IR people, and non-IR people. I put the dots there because I'm putting results on top of each other, so I had to differentiate that. So the glucagon of the IR people are polka dots, are dotted. And the glucagon of the non-IR people are solid, right? So pretty straightforward. We can eyeball it and we say, well, look at the difference. Then when we put them on top of each other, same two graphs, I shrunk them and put them on top of each other. When you look at glucagon, one glucagon for the non-IR people is level or actually decreases over the course of inflammation. From, when I said you want to be under 1 all the way up to 9, it's pretty much level to slightly decreased. Whereas for insulin resistant people, their glucagon is zoomingly high. So you start asking what's happening with insulin resistance. Insulin resistance obviously is about the pancreas, and it starts to make the insulin ineffective. Either the production of, not enough, or the quality of isn't as effective. So it's closing in on the liver, affecting the pancreas. So glucagon also comes from the pancreas, so that's equally affected. In other words, it's getting a little bit out of whack. It's overreacting. So remember, HOMA-IR over 1.4 are IR people, insulin-resistant people. Now look at the non-IR glucagon. Now I added in insulin, which is interesting, but glucose and glucagon have a pretty similar wide range, so you can compare them. Insulin is far narrower, so it was a little bit wrong of me to throw that in there, but because it shows that it's level, which it is generally, but when you have a small range, as I mentioned before, it tends to reduce the amplitude of change. So there you go, glutathione, glucose, glucagon, glutathione, you see that decreasing for everybody. This is for everybody, undifferentiated. Now this is IR versus non-IR. Here I happen to do the non-IR with the dots. So it looks here for the non-insulin resistant people, you have glucagon decreases with glutathione, right? So this is just the opposite of what we saw with inflammation. So you add in, if you will, glutathione, and it drops the glucagon for the insulin resistant people, but it actually increases the glucagon for the non-insulin resistant people by, I won't say adding, it's those who have higher. You might say gave them a little more strength, a little more ability, or brought them up to a normal range. I don't have the range listed here, but it's pretty much in the middle there. So it's pretty interesting that if you look at the mid-range is right around here, it brought the insulin resistant people down, their glucagon down to normal, and it brought their non-IR people a little more robustly up to more or less normal. So it works both sides, but mostly for the IR people. All right, insulin and age. What happens with age? Well, generally, if I throw everybody into the same kettle of fish and go, hey, insulin goes down over time with age, it does from 15 to 80 for my data. You go, wow, that's pretty interesting. Well, you break it down into those two groups, because everybody in reality are in those two groups, metabolically speaking. Insulin resistant people, their insulin actually increases over time. It gets worse over age. So from 15, it doesn't get, not terribly, but it increases. Starts off a lot higher, insulin-resistant people. It gets even higher. And non-insulin resistant people, pretty much level and decreases. So it's, look at it, the starting point for the trend lines here are significantly different. So non-IR are far lower for insulin for their whole lives. And it tends to get less as they get older. Insulin and glutathione now. So insulin, glutathione, we're adding it back in, right? So here's the undifferentiated group, and we're saying, all right, those with higher glutathione levels, which for the most part are younger people, right? They're not taking it as a supplement, are mostly younger people. We find that their insulin is lower. So more glutathione, lower insulin. Now we break it down into those two groups, representative reality in the world, and you have insulin decreases fairly significantly for IR people and increases a little bit, just like with the glucagon, increases a little bit with glutathione. Interesting, eh? So two different patterns. It's not a one size fits all. So there's no way, if you were to go, hey, this is everybody, and your doctor, you're talking to your doctor, said this is what happens for everybody over life. Well, that's not true for non-insulin resistant people. All right, so just putting the charts side by side, we have age and glutathione. So insulin, IR people, non-IR people, age here, and glutathione. Again, it's a mirror image. So you can almost say, or am I saying by this data that glutathione is an anti-aging? It's making the older people look younger by these labs? I think it's a big factor. And I think our loss of ability to create glutathione has a lot to do with our aging process. That's a whole nother series of videos I've done. Okay, glutathione, HOMA-IR, and pounds overweight. Nobody likes to talk about obesity or pounds overweight, generally speaking, especially if you have, and I'm not doing BMI, especially if you are overweight. You get tired of feeling you're recognized for being overweight. So I'm not going in that direction, but I'm going to show you some surprises. All right, so glutathione, HOMA-IR, basically the more glutathione it drops, brings down your HOMA-IR, so you become less insulin resistant, hopefully back to normal. And pounds overweight, the heavier you are, this is an undifferentiated group, the higher your HOMA-IR, right? So they're mirror images. So by that, it's a bad thing. So now we break into those two groups, IR and non-IR. What do we say? Well, with poundage overweight, we find in glutathione over here, poundage overweight with increasing glutathione. Those who are overweight, those who have the highest glutathione, I should say, had the lowest weight. Is glutathione a weight loss remedy? No, but if you're working efficiently, you tend not to gain weight, is how I look at that. But what about the non-IR? The non-IR people, you say, well, they're already pretty healthy. They're already under 1.4. And you're saying, well, they, with increasing glutathione, it looks like as their weight went up, they generated more because they had the ability, a better ability to generate glutathione. And that's what they did. Eventually, if they got heavier and heavier and heavier, they would get into being an insulin resistant person. But initially, they can be insulin resistant and be overweight. So it's not bad news for everybody. But they have the metabolism to respond to it, to counter the negative things of weight and probably to bring them back into a normal range. So back to who's at a higher risk of serious symptoms. These conditions all have one thing in common, and you know that by now, and that is a seriously impaired ability to make glutathione. All right, so here's from the Mayo Clinic from the previous video, 5 vulnerable areas, vulnerable groups of people to COVID and respiratory viral infections in general. Older age, can't do much about that. Diabetes and obesity, talk a lot about that. That's basically insulin resistance. Heart disease, pretty much part of the above. Weakened immune system, pretty much part of the above of insulin resistance. Chronic kidney or liver disease, pretty much part of the above. So basically it's either older age or insulin resistance. Okay, so you have insulin resistance and genomic mutations that limit their ability to methylate. And having both makes it far, far worse. The big five, the most vulnerable groups to respiratory viruses, as I say, are diabetes and obesity. And the reality is most are a subcategory of that. Everything but age is a subcategory of diabetes and obesity. It really should be called insulin resistance, high or low, right? You could be 1.5 and you could be 30. Obviously there would be, but it's a scale and it's a category to look at. And that's what's unique about this. Something you can do about it. And it's a number to say, if you're 30, you're very vulnerable. If you're 1.5 or under 1.4, you're not that vulnerable, right? Weakened immune system, heart disease, chronic liver disease. Break it down into two groups by addressing predispositions to respiratory viral infections and those when you actively get exposed to respiratory viral infections. Onset, acute, resolving, or not resolving. Onset, acute, recovering, and then we're talking about COVID, you have still those who have long COVID. It's gone on for more than months. But starts off, virus you're exposed to. Does the virus replicate? Maybe a little bit, maybe not at all. And it's all about your ability to respond to it. Can you stand up to the virus? Can you stand up to the virus? We talked about genomic predispositions, right? That's a big deal. Can you stand up to the virus? Can you respond to it? Can you not allow it to increase viral load? Okay, so onset, runny nose, headache, scratchy throat, body aches, inability to sleep. When it hits you, this is how it will go. Boom, boom, boom. Acute, fever starts. Fever, don't prevent a fever, by the way. Shortness of breath, cough, extreme exhaustion. This is when I'm not going to work today. I just got to lie down and catch my breath and maybe I think I'll sleep. And inflammation gets worse. So recovering is still feeling lousy, still very tired, shortness of breath, cough, extreme exhaustion. Eventually things start to improve. Or they don't and you have long COVID, or you have long respiratory distress syndrome. Why insulin-resistant people react differently when they get a respiratory virus. Any of these, of the trifecta. Okay, let's just look at some of the factors that you can address. So I'm not going to go into, hey, lose weight and exercise. Those are all good things, but I want to go a little deeper and a little more useful because I don't think that's really useful information. So what I'm going to say is omega-3. So what is omega-3? Yes, you get it from fish and seafood. Basically, it's a supplement you also take. It'll help, a good supplement. And I'll end up with the supplements in it. But omega-3, nobody thinks about taking omega-3 as a flu prevention, do they? Because you weren't told to. Because they didn't do the research. But they did. I'll show you that. Homocysteine. So we have homocysteine, which we've read about, for insulin-resistant people, decreases with increasing omega-3. And your omega-3 should be between 8 and 12, and that is percent of fatty acid, red blood cell, but who cares? Anyway, it should be between 8 and 12. Homocysteine decreases. It decreases actually more for the non-insulin resistant people, but it comes down either way. Homocysteine, omega-3 is important to bring down homocysteine. Omega-3 brings down insulin resistance, HOMA-IR. Holy smokes, look at that. Here's your goal, omega-3, you want between 8 and 12. You bring it down to your range, and more than likely, your HOMA-IR will drop as well. So I didn't talk about pounds overweight. I didn't talk about go out and exercise. Those are good things, by the way. Omega-3 and linolenic acid. We've heard a lot about seed oils that you get through your mayonnaise or the food you're eating, but the more omega-3 you have, bring that into range and you can measure it. So that's an omega-3 index, they call it. It's phenomenal. It just sort of rights the boat, if you will. Okay, so here's now the ratio of linolenic acid, which is omega-6. It's not the only omega-6, and omega-3. So as that ratio gets worse, in other words, you have more linolenic acid because you're eating lousy foods and processed foods. This number over here is not about omega-3. It's about you're very heavy on linolenic acid. It gets worse and worse and worse. So for both sides, or parallel lines, it gets worse for both IR people and non-IR people. Let's change that. Now we bring up their omega-3 between 8 and 12, and what happens? Does just the opposite. Drops it down. This is pounds overweight. Adding omega-3 is we talked about glutathione. Pounds overweight, those within range, 8 to 12, weigh a lot less. So the implication is, can't say this because this is my data, it's not a formal study, is that is one way to drop weight. Am I saying omega-3 is a weight loss remedy? I'm saying put that on your list with the glutathione, and the list will continue. Pretty cool. Okay, the omega-3 factor versus pounds overweight, to be very specific. That was the 6,3 linoleic acid omega-3. The more linoleic acid, the worse it was. The heavier the worse. So the heavier people, the way I read this, the worse that ratio, the heavier you are. You change that ratio, you change your weight. Over here, just the opposite. You increase your omega-3, It correlates with a lot lighter people. I think that's phenomenal. So here's some studies now. It's not just Dr. Carl going in his own little mind. Habitual fish oil use and the risk of COVID-19 related outcomes. Evidence from a large-scale cohort study in China, 2023. 2023, just last year. Conclusion, in this large cohort, we found that habitual fish oil use was significantly associated with lower risk of SARS-CoV-2 infections, hospitalization, and death from COVID-19. Analysis further supports a possible causal role of DPA. So DPA is another omega-3, and it's between DHA and EPA. It's another omega. So if you're taking fish oil, you get that as well. Your body changes it. Okay, and there's a link for that. Also, associations of habitual fish oil use with risk of SARS-CoV-2. This is from the UK, and this was in 2022, a year before. Habitual fish oil supplement is associated with lower risk of hospital admissions and death with COVID. Pretty important, okay? So I wasn't just making it up for fun. By the way, interesting metrics. The association of fish oil supplementation with decreased incidence of dementia. Just one more reason for you to do your fish oil and to do your labs so you know, and I have a whole other video of fish oil and why you need to do that. But do those labs once a year at least, a couple times a year until you start to understand yourself. This is a big metric. If you can't measure it, you can't change it. People go, nonsense, nonsense. A lot of people want to believe they don't have to measure everything and they can change their life. They can, but most of the people that I see have gone too far in taking these things they thought were good for them, and now they realize it didn't quite work out. Can I see a little more formal approach in somebody who knows about labs? Anyways, so there you go with dementia. It's another one, effects of SARS-CoV-2 infection in the cognitive functioning of patients with pre-existing dementia. Okay, the background was codename cognitive COVID or brain fog COVID, characterized by multi-domain cognitive impairments, are now being reckoned, I like that, it sounds like an Australian study, reckoned as the most devastating sequelae of COVID-19, brain damage. Conclusion regarding dementia and fish oil, I believe. The rapid progression of dementia, in addition of further impairments, deterioration of cognitive abilities, and the increase or new appearance of white matter lesions, which is how they recognize the dying of the brain, that previously comprised brains have little defense to withstand a new assault. The second hit idea, they're getting one hit, another hit, another hit. So if they're already vulnerable, they're going to take a big hit. So dysregulated immune response and inflammation. So omega-3, vitamin D, and glucose. So notice the bottoms, omega-3, omega-3, omega-3. Vitamin D and omega-3, vitamin D and omega-3, glucose and omega-3. So what are we looking at? Everybody, undifferentiated group of people, IR and non-IR, as their omega-3 increases, their vitamin D increases. By the way, what products do you know in life in general that have both omega-3 and vitamin D? Cod liver oil. You can say fish oil in general if you actually eat, but cod liver oil is liver oil. So it's not just eating a cod or eating fish, it's eating cod liver. And having lived in Norway, lutefisk was not one of my most favorite things. I won't say it was cod liver, but you only can go so far with cod liver. So cod liver oil is anyway very helpful. Liver in general is very helpful. Okay, back to this. So what we're seeing is now omega-3 with vitamin D, it goes up, but it really goes up for insulin-resistant people, those in greatest need of vitamin D. Vitamin D has to be activated, right, by your liver to be passed on to your kidney and then go out and be active and support your immune system. But what this shows is that it really affects the IR people by a lot, and it does have a benefit for non-IR people as well, but nowhere near what it does for insulin-resistant people. Glucose. Remember, glucose is part of the HOMA-IR, glucose and insulin. So as glucose goes up, as people are close to diabetic or they're getting sick, however you want to look at it, and if your omega-3 is way over in the good range between 8 and 12, what do we see? Well, if you bring your omega-3 up there, you're going to drop your glucose. Omega-3 drops glucose? Amazing. But in a non-IR, you increase your omega-3, it actually brought that up. But where the normal range for glucose, it's really between 75 and 100, so they've stayed within range. It's interesting that it brings it up to slightly higher. Why that is, but it doesn't go out of range. 135 is way out of range. So these are fasting numbers, by the way. Potential of omega-3 supplementation for coronavirus disease 2019. Conclusion. Existing studies considered that omega-3 fatty acid has a potential in COVID-19 by reducing risk of positive COVID-2 infection, shortening the duration of the symptoms, right? You get over it quicker. You were exposed to it, you had it, and you were strong enough to get over it quickly. Decreasing the risk of renal and respiratory dysfunction. Increasing patient survival rate. Always a good thing. Now ask yourself, why? Self, why is this the case? That was from Indonesia. I love how the international sort of thing. All right, so why should you not take aspirin? Take 2 aspirin and call me in the morning. Don't do it. 2 comments, need a response from the last video, and I love going into this. Here we go. They missed my point, but they had great comments. But from a limited perspective, very conventional medicine, 2, it looks like retired nurses or active nurses. Here we go. Number 1 was, also, most of my life I worked in the ICU and in-service education. The last place before retiring was in a big New York City hospital with Dr. Oz, little name dropping there. This was a CT ICU unit where they did heart surgery and lung heart transplants. We had really sick patients on, that's basically the dialysis machine, and ECMO, which is the lung heart machine, or bypass machine. I never saw someone going into acidosis or dying from aspirin, but I saw several die or have their liver shot from Tylenol overdoses, and it does not take that much. So how much aspirin were these people taking before they went into acidosis? That's a good question. And acidosis in medical school, and I'm sure they had to do it too, I don't know about nursing criteria, but you have to memorize things a lot. And one of the mnemonics for metabolic acidosis is salicylate toxicity. So salicylate toxicity is aspirin or Pepto-Bismol for the most part. You get salicylates through food and so on and so forth, but you don't get toxicity through food. You get it through people just saying, I feel lousy, I'll take another aspirin. I feel lousy, I'll take another aspirin. So in that sense, they've gone too far. Aspirin does help prevent from clotting. So in certain extreme cases, which we'll read on in a second, it was helpful. But that's not my point. I'm not talking about those extreme cases. I'll come back to my point later. Here's another person who says, you're wrong about aspirin. You even admitted it there. Those deaths were caused by misusing aspirin in high doses, but low dose aspirin, a lot of capitals here, actually saved, capitals, COVID patients on ventilators by preventing blood clots. Absolutely. They are what they call a cyclooxygenase inhibitor, and they block the production of thrombocytes, hence, stopping the blood from clotting. So that's a good thing in that extreme situation. Also, the reason that many COVID patients did die on ventilators is because the hospitals failed to use a necessary first step before using a ventilator, which was using inhaled corticosteroids, steroids in general, to shrink the swelling of the lungs before shoving the ventilators into swollen lungs. Also, studies can actually be biased in favor of drug companies' agenda. Absolutely agree. Absolutely agree. The media lies for their drug company sponsors, absolutely agree. And the supposed study that you cited here I cited a number of them, was from a New York Times, which is one of the most biased news companies in America. And guess what? I agree, I agree. I cited New York Times because it's a common reference, and it was on the data, not so much a study. Also, I recently saw a very credible scientist promoting all the benefits of aspirin that one was not spoken of in the mainstream media, which actually makes it more credible. There are benefits to aspirin, so aspirin is not all bad, but they missed my point. I appreciate these comments. They didn't have any negative. They didn't accuse me personally. They said, these are my opinions, this is why you're wrong. That's a very healthy conversation to have. I encourage that. Disagree with me. I want you to disagree with me, but you don't have to, avoid profanity and so on and so forth. So what they missed was aspirin is an antipyretic. Another word there, it's also an antidiaphoretic. What does that mean? It stops you from having a fever. It stops you from sweating, which means it prevents you from having a fever exactly the moment that you need it. So a fever is your way of getting it out of you. It's your very first step. So if you're going to take aspirin, I'm feeling a little lousy, I'm going to take aspirin, you've blocked that very first step of your body, allowing it to generate a fever, to kill the pathogen, to kill the virus. As you'll see, we're going to get into it. But if you've taken offline, you've unplugged the light, so to say, it doesn't work. Now things are automatically going to be worse. Things are automatically going to be worse for you. Okay, so you've blocked the fever. It's an antipyretic and it's an antidiaphoretic. Why you need to let yourself have a fever first. This is why you don't load up on aspirin. Let fever do its job. This is actually the title of a paper, The Meaning of Fever in the Pandemic Era. And this was US and Poland 2021, smack in the middle of the pandemic. Fever suppression does not improve outcomes. Human interventional studies. Evidence from randomized controlled trials suggests that intervening to reduce fever does not improve patient survival time. 1. Some human trials have shown harm from reducing body's temperature lower than normal in critically ill patients with infections. 2013, a randomized trial using chilled intravenous saline to induce hypothermia in patients with meningitis. Pretty critical condition, was stopped early after an interim review revealed increased mortality in the intravenous cooling group. Wow! They were dying. Those who had the lower fever-lowering mechanism died. 2. A more recent trial studied mechanical cooling of critically ill patients with septic shock. This trial randomized patients to induced hypothermia using an external chill circulating water, compared to those receiving usual care, which included some medications such as acetaminophen. The trial was also terminated early after enrolling 436 of the planned 560 patients. Interim analysis pointed to higher death mortality in the mechanical cooling group. Even medically fragile patients, including those with heart disease, limited physiological reserves, did not benefit from intensive efforts to reduce body temperature. Taken together, these studies suggest that survival outcomes of patients with infections are not improved by intravenous interventions used to lower body temperature or suppress fever. And there's the study, said randomized trials of body temperature reduction using intravenous or mechanical cooling have shown a signal of harm. These results are in line with an increased death in observational trials, that interfering with physiological set point for body temperature can have unintended consequences. That's my point. Not that it helped with preventing clots, and forgot what the other person's comment was. So there are benefits to aspirin, and my point is you don't take aspirin at this point when you're starting to get a cold or a flu or respiratory virus, okay? So basically it comes down to this. The benefits are heat stimulates most immune functions, heat directly inhibits and harms pathogens, likely synergy of immune stimulation. And the costs are, it's uncomfortable, primarily discomfort, distress over fever phobia, don't let it get too high. And in children, clearly you have to monitor fever. So this isn't really about children, this is about adults and so on that are by themselves. To go even further, here's what we do. So if you really feel you're getting sick, having a hot bath, I'm not talking about a hot bath, I'm talking about a really hot bath to the point that it's called hyperthermia. Hydrotherapy is what I meant to say. It's alive and well. It's an old treatment. I've actually gone to Europe, Czech Republic a couple times for a couple weeks to study their data and using various forms of hydrotherapy, and hot baths was one of them. They're really hot baths, and to the point that you really need somebody in the room with you to watch you, and sort of you're in there very slowly for a couple of minutes. You probably can only be in this hot bath for 5 or maybe 10 minutes. So in that bath, put magnesium salts. You can take electrolytes if you want to, but also drink a tea, and it's best to drink a tea that makes you sweat. So famous diaphoretic teas, right, are ginger and yarrow, or you can have some extract of ginger and yarrow, put them into water. It doesn't even have to be hot water. You're drinking that, so you're sweating. You also obviously can go into a sauna for the same reasons, but make it sweat. Work in the direction of not stopping a fever, but pushing the fever out. And then after that, dry off, go to bed, go to sleep, get in your PJs, go to sleep, done. But that's what you need. You need the hot bath, the Epsom salts. And what I would suggest you not put in is essential oils. A lot of people say you can go, well, I'll put in a eucalyptus oil because it breaks up, it's like a mucolytic. It is, but eucalyptus is also cooling, and so is spearmint and a few other things, and that would be against the bigger thing. So later you can use eucalyptus, like Vicks Vapor Rub is a salicylate. It's methyl and camphor with eucalyptus. But at a later time you can do that. Initially you want the fever to break and you want to support that fever, and this is what you would do. Mild fever helps clear infections faster, a new study suggests. This is out of University of Alberta, Canada, and the summary point is this, and I'm now sort of stated a number of references. I want to date this. This is 2023, so this is new. This whole reconsidering the value of fever. Seriously, I'll show you things in TCM, Chinese medicine, that go back thousands of years about fever. So in 2023, so it's really being reconsidered. Better to let the fever run its course instead of automatically reaching for medication. New research suggests. Researchers found that untreated moderate fever helps fish clear their bodies of infection rapidly. You got to work on what you got, right? Controlled inflammation and repaired damaged tissue. Moderate fever, self-resolving. It just really is interesting, meaning that the body can both induce it and shut it down naturally without medication. So it means they didn't give any aspirin to the fish. Moderate fever cycles has a potential mechanism to protect respiratory system in COVID patients 2020, and that is out of Israel, US, and Switzerland. Fever and thermal regulation of immunity. The immune system feels the heat. 2015 in the US. These are the journals, and you can look these up, pop these into Google, and away we go. Okay, here's what I wanted to show you. So having spent 3 years of acupuncture, Master of Science in Acupuncture and certification, of course, and then 4 years memorizing Chinese herbal medicine, I know a little bit about it. And so I just want to show you table of contents of 2 books that I have. One is you have to go in, you have to memorize single herbs. And then you go into the formula. Everything becomes formula. You're about making formulas, but you really need to know all about the herbs first. And there's a lot of memory for TCM, traditional Chinese medicine. So TCM, straight from traditional Chinese medicine. These are the single herbs and these are the formulas. The very first chapter is herbs that release the exterior. Release the exterior is make you sweat, that help you induce a fever. It's that important. It's their #1 thing of all herbs, is help you induce a fever. And here we are in the West saying, don't do a fever, that's so uncomfortable. Don't do fever, don't do fever. Don't be stupid. Your body wants to have a fever to fight it off. Don't block what your body needs for you. So anyway, the first chapter is warm, acrid herbs that release the exterior. And then goes on to cold, acrid herbs that release the exterior. Absolutely fascinating and fun to know about. I appreciate that time. Formulas, chapter #1, formulas and strategies. Formulas that release the exterior. Formulas that clear heat. Amazing. That's how important it is. So the last word on the importance of fever, and herbs and in formulas. Okay, now vitamin D, which we've all heard so much about all the time. So vitamin D, insulin versus vitamin D, and HOMA-IR versus vitamin D. So you know on the outset that HOMA-IR is made up of insulin and glucose, right? The formula is insulin and glucose. So of course these are going to be related. But it's really interesting to see that when you get your vitamin D up into a normal range, and what I consider a normal range is really between 60 and 100, so call it 80. All right, so 80, if you have this is your 25OH serum blood test vitamin D level up into the range of 80, look at the correlation or association with insulin. It's like those who have the highest vitamin D have the lowest insulin. I mean, that's very impressive. That's a very positive relationship. It's almost a perfect relationship in terms of reverse, when one goes up, the other goes down. But notice that the relationship is primarily with insulin-resistant people. The non-insulin resistant people, those who are metabolically healthy, really, they do get a benefit that their insulin also goes down a little bit, but not much over a big spread of vitamin D. Now look at HOMA-IR. It drops like a stone. Again, it's like the same angle for the most part. Get it up around 80, and your HOMA-IR will drop. So my point is, in looking at these smaller factors that have to do with HOMA-IR, which is one of the factors that makes you a vulnerable person or a vulnerable group, as opposed to and including the SNPs, the metabolic SNPs, it's a big deal. So addressing these little things that can change one of those 2 factors, and arguably that's the biggest factor for why people are vulnerable to a respiratory viral infection. Insulin resistance versus non-insulin resistant people. Lymphocytes. So why did I choose lymphocytes? So lymphocytes is part of your white blood cell, WBC, part of your CBC blood test, which is like the $10 blood test. So when I order a CBC, it's a CBC with diff, which simply means it breaks down the white blood cell components to neutrophils, lymphocytes, monocytes, basophils, eosinophils, etc. But lymphocytes specifically are the antiviral. They're the part of your immune system is antiviral. Neutrophils are more bacterial and fungal, and nothing is ever black or white. They overlap, of course. But this is primarily the antiviral aspect. So I'm interested to say, hey, what is the relationship between people who have a high HOMA-IR and other things relative to lymphocytes, right? We're looking into viral respiratory infection. So how does that look? Here we go. So lymphocytes for HOMA-IR, the higher your HOMA-IR, or way up into the 30s, 25 and 30s, look at the relationship. The higher your HOMA-IR, your insulin resistance over 1.4, that the higher will be your lymphocytes. And here's the range for lymphocytes. So you can say, well, it's all arguably within normal range. It is true that is, but it's still, I think it's a very broad range. And so this basically shows the worse metabolically you are, the higher lymphocytes are going to be. The more amped up is your immune system. Sets the stage for autoimmune, and that's another issue. Okay, what about glutathione? Glutathione is kind of the opposite. So how does glutathione affect our lymphocyte counts across the population? Dr. Goldkamp's population. Okay, so the higher the glutathione, the lower the lymphocytes. So it's just the opposite. So glutathione, as much as we kind of suspected this way up front, is kind of the antidote, or it's the opposite. It's really necessary. So once the HOMA-IR people, they're losing their ability to create glutathione. So here it is, if we give them that ability back, what happens? Well, their lymphocytes come down. I think that's just profound. You know, I wouldn't have seen that otherwise had I not been able to have the data and do the scatter plots and go, you know, yeah, I get the logic of this whole thing, but to actually see this, profound. So with insulin-resistant people, really interesting, what it shows here is now IR people, that glutathione, the more glutathione, it brings them up to a reasonably strong immune system. For, it's really interesting, non-insulin resistant people, it brings it down. It sort of like tones them down. So just to put it out in front of you, HOMA-IR is a straight line, right? We're going from 0 to not quite infinity, but certainly in the 30s and 40s, very high number for HOMA-IR, which is insulin resistant. So I wanted to break it down. Between 0 and 1.4 is non-insulin resistance. HOMA-IR number, which we calculated way up front of this video, shows that you are non-insulin resistance. Everything after that is low insulin resistance to higher and higher and higher. And so on that line, there's certain milestones that are kind of conventionally established. So 1.4 is in line. 1.9 says, well, this is early insulin resistance in terms of, well, now you're getting kind of serious insulin resistance. 2.9, almost 3. You know, why don't they call it 3? Why don't they call that 2? Got to be a little precise. All right, insulin significant resistance here, it's getting deeper. And clearly, when it goes beyond that, we've seen people up in the 30s. So you have obesity, you have non-alcoholic fatty liver disease, and it gets higher and higher. You certainly have prediabetes and it ends up with diabetes, and then depends how far it goes. But that's the range. Non-insulin resistance to insulin resistant people, getting worse, going over towards diabetes, HOMA-IR. So now you have it in your mind. I just wanted to sort of put this on the world. It's like, well, if we're measuring insulin resistance, which is really, I couldn't find a graph like this globally, so I used diabetes because diabetes is kind of the extreme endpoint for insulin resistance. Now, what is going on in the world for insulin resistance? There's a few surprises here. Yes, the United States was the highest back at the turn of the century, 2002. So this is 2002 to 2015. And what do we say? Well, it starts off with the United States as the highest, and roughly 13 years later, the United States is no longer the highest. It got higher by a little bit, but Singapore got a lot higher than the United States, Taiwan got a lot higher than the United States, and Mexico got a lot higher than the United States. Interesting. Countries that have not really dramatically increased in 15 years were Russia, UK, Bosnia, Herzegovina, and Australia. So the question before all of us is about the insulin resistance and respiratory viral infections is this. Do we not realize we're playing with fire by having a population that is getting to be a higher and higher percentage of insulin resistance, if not prediabetes and diabetes? We hear that all the time. I didn't even mention the word obesity because obesity is just a point on the range. I'm talking about insulin resistance over 1.4. We're playing with fire. So at first we start wherever we start. You could say it's diet, but we start over 1.4. It grows. It starts with small fire, small incidents, maybe neurologic, maybe arthritic, maybe cardiovascular, and then it gets worse. House catches fire, house burns down. Now you're talking about severe damage, dementia, amputation even. So whatever you want to measure it, it is part of something that's growing to a catastrophic level, which is something easy to address. And my whole point here is not saying, oh my gosh, we have a catastrophe, we're all falling apart. The point here is to take action for yourself on a simple test. Know where you are so you can catch yourself saying, I got to go back. I got to pull back to make myself healthier because it's your responsibility and it's within your ability to do this. That's the point of this. So the two common predisposing factors, insulin resistance and methylation SNPs, single nuclear polymorphisms, that cause glutathione deficiency is the big deal. And the respiratory virus or the respiratory viral infection is really the match that starts the whole thing. If the hay wasn't so dry, so the two common predisposing factors are the dry hay. And if the hay wasn't so dry, if there wasn't so much insulin resistance, and if there wasn't so many people like myself that have those predisposing SNPs, put them together, it's a big deal. If the hay wasn't so dry, the risk would not be so extreme. To go from being exposed to a virus to having the virus replicate in us by borrowing our methylation system, if you will. It's all about our ability to control the virus, to keep it from replicating, to take ownership over our own methylation system, if you will, looking at it that way. So if we can control that by not being insulin resistant and controlling our SNPs, knowing we have the SNPs, and it's not an endless project for that, we can keep the hay from being so dry and keep ourselves individually from being so vulnerable. Pretty much the last note here Some people have never fully recovered from the pandemic. We know this, and we call that long COVID. That's a big deal. If you know anybody, you know the story. You know it's a sad story, and they're not coming out of it that well. Initially, it was a few months, so it's anything over 90 days was long COVID, then 4 months, then a year, and now it's been a few years. Okay, so symptoms such as fatigue, difficulty exercising are common in people with long COVID and can persist for months after infection. This is actually from an article in Nature called The 4 Most Urgent Questions About Long COVID in 2021. Again, the progression is, can we control the viral replication? We're always going to be exposed. We live in the world, we're exposed to a lot of things. So it's not like lack of exposure. It's not like we're going to mask ourselves up, which did no good anyway, or put ourselves in armor for a month or two, or stay home, shelter in place as they used to call it. Sounds so innocent back then. No, it's not. It's about building yourself up and identifying your vulnerabilities. It's taking care of the terrain. It's taking care of your personal baggage, for lack of other words, metabolic baggage. So this is from a study in Brazil, which I think is amazing, 2020, and it was looking at the people pouring in with COVID, and they found there was 3 groups. Those who got over it about 5 days, and here they're just talking about COVID progression. So viral load versus inflammatory response. 5 days, mild disease, they got over it. 10 days, moderate disease, inflammation's a little more, viral load was a little greater, but they took care of it. And then uncontrolled, severe disease, no resolution, stage 3, which they call it. Now you're at acute respiratory distress syndrome, otherwise known as ARDS. So to long COVID or even to death. That's how it progresses. That's the reality. And so the responsibility falls back on our own shoulders individually, finding out the factors for ourselves. Okay, now we're doing glutathione to glucagon. Remember I talked about glucagon is the thing that starts driving your glucose higher and starts the beginning of feeling awful when you have a flu. So those who had higher glutathione had lower glucagon. So higher over here. So you go higher glutathione to lower glucagon. That's a big deal. So we keep on coming back to one of the themes is glutathione for sure. Can you take it? Can you create it? Can you maintain it? So now we break that one size fits all, that's undifferentiated data, to those 2 groups of people, IR and non-IR. What do we find? The healthy, metabolically healthy people, what happens is that as their glucagon increases, right? They're starting to get sick. The glucagon starts to rise. They have the ability to generate a lot of glutathione very quickly. It doesn't take much of a stimulant of glucagon from the pancreas to stimulate all that glutathione. That's what healthiness, that's what metabolic health looks like. At the same time, those who are insulin resistant, as their glucagon increases, as they get sick, what happens? Their glutathione drains away. They can't keep up. It gets to be too much. So back to homocysteine. Omega-3 drops homocysteine, which is the same thing. Omega-6-3, a slightly different ratio. It's kind of like the linoleic acid. What you have is, as things get worse, so that as you get more omega-6, your homocysteine goes up. Think of seed oils. Think of too little omega-3. Okay, why some people get very sick? High glucose, high inflammation, low glutathione. You saw this from the very beginning. Glucose versus inflammation. This is the non-insulin resistant people. Insulin resistant people, dramatically different responses to the same situation. When exposed to these flus, right? Exposed to the trifecta of respiratory or viral infections, glutathione versus CRP. Here we go, glutathione versus CRP. They're both CRP, both inflammation. So when we start adding in glutathione, or those who have higher glutathione have lower inflammation. That's what is very straightforward. Those with higher glutathione have lower inflammation. So the people that are insulin resistant, as their inflammation goes up, they don't have the ability to generate glutathione. They can't increase their glutathione. This difference is solely about their insulin resistance. Again, inflammation goes up, their glutathione goes down. All right, so remember this. Remember from the very beginning, COVID-19 and methyl salt attack on our methylation. Here we have talked about SAMe, and there's MTHFR. And the interesting thing is if you don't have SAMe, it's one less factor that will drive this particular enzyme. And if you have mutations like myself, you're kind of crippled in a number of ways. A methyl salt group prevents you from making glutathione. All right, the factors that create glutathione deficiency, this is from a Polish study. So endogenous deficiency of glutathione as the most likely cause of serious manifestations and death in COVID-19 patients from 2020. Again, virus replication, increased viral load. Can you manage that? Your ability, your glutathione is directly involved in minimizing the viral replication. So what do we know by this? Over age 65, low glutathione intake, and that usually is not about supplements, it's about food, The number one source of glutathione really comes from meat, genomic predisposition, we talked about that, same study. Lower in males, cigarette smoking, obviously, lungs, and chronic disease. Add this, those darn methylation SNPs. In other ways, these are the common bottlenecks, MTHFR, MTRR, homocysteine increases, glutathione decreases, but it doesn't have to happen. That's the thing, it doesn't have to happen. You can intervene. If you know about this, which is not real sophisticated information, it's a great story, but it's easy to find out where you are in all this. I just pulled out some of my data to look at HOMA-IR and vitamin D, because there was a study that said vitamin D correlates negatively with insulin-resistant levels. Here's insulin-resistant levels, and sure enough, it shows the higher the vitamin D, the lower their insulin resistance. So the point being is non-insulin resistance is far more important than the level of your vitamin D, but you need to pay attention to both. So what happens to your electrolytes when you get sick? Calcium, magnesium. Here we have, as your inflammation goes up, calcium actually drops. It drops more for non-IR. So here we have magnesium, how we measure it, red blood cell. We find as your CRP goes up, your magnesium increases. It comes out of your red blood cells and it decreases. Point here is dramatically different responses for IR and non-IR. And here we have, with calcium, similar responses, but they're just measured apart, different levels, both in the beginning and the end. Okay, electrolytes, when you get sick, sodium. IR people, sodium goes up. Non-IR people, sodium goes down. Whoa, talk about completely different. So we do not have a one-size-fits-all. Potassium, pretty similar response like calcium, but they're whole different levels. They go down both in RI and non-IR in IR people. Next, sodium-potassium ratio. Why is this important? It's a general indication of stress, adrenal stress in particular, indication of possible cardiovascular events, stroke, heart attacks. So dietary sodium to potassium ratio, easy to calculate, very cheap. It's a $4 test. Talked about that in a whole nother video. As a risk factor for stroke, cardiovascular disease, and all-cause mortality. This is from Japan, 2018. Same thing in 2023. Dietary sodium-potassium ratio as an independent predictor of cardiovascular events. Here you go. Here's just measuring it. Same thing from the data that I have. What do we find? Is inflammation increases. Insulin-resistant people, their sodium-potassium, their stress goes up, way up. Whereas the non-IR people, the metabolically healthy people, it stays level or actually decreases a little bit. They can handle it. They can make the things they need to take care of it. So why take electrolytes when you're sick? It can be very helpful. Through the lens of comparing these two groups of people, insulin resistant and non-insulin resistance, look at this. Look at the change of that ratio of sodium to potassium, adrenal stress, right? Adrenal stress, cardiovascular stress, and glucose as you're getting sick, as your glucose is getting higher, or as you're becoming more diabetic. You find that insulin resistant, the ratio zoomingly high, whereas just a slight change for non-IR. So the point here is if these two completely different groups, right? Now I've really conned you into, now hopefully I've convinced you there are two different groups of people always in the world, metabolically healthy, non-insulin resistant people, and metabolically unhealthy, from a little bit unhealthy to very much unhealthy. These are the two groups. If these two groups, completely different groups, are treated the same way, one group will be overtreated. The other group will be undertreated. And I end with this. I said, this is not medicine, it's incompetence. So now what you can do, what you need for your viral respiratory first aid kit. So this is where we started, and this is the list of things to have. And I put at the top liposomal glutathione, liposomal vitamin C, electrolytes assure, ongoing NAC. We'll get into NAC a little bit in a second. These are the kingpins up here. Vitamin D, K2, with magnesium citrate I prefer, but you could use glycinated malate. Zinc, throat lozenges. Zinc is not about being zinc deficient, which zinc does have a lot to do with your immune system, but at the time of onset, this is what we're talking about. The time of onset, you're starting to get into acute here, is that it is a shield. So it's something you want, it's a lozenger because you want to suck on it and keep it coating your respiratory in the back of your mouth and your nose, basically your ACE2 receptors, if you want to go there. But that's why you need to suck on it. It pretends to be like a baseball glove. It protects you. So that's why you're using it, not about deficiency. Also, you notice they have omega-3 down there. You have vitamin D, we talked about that, glutathione. All the big movers are really effective. And so what I do in terms of reality, if you're feeling lousy, I don't see there's really an upper limit to, I do an oral 3 or 4 times a day if I'm feeling lousy. Same with the liposomal. These are liposomal. You get them in, you'll see it in a second. Electrolytes somewhat. Certainly the bath, I've told you about that, the hydrotherapy. Okay, important thing is to have these on hand. You don't need these, you have these on hand. Most of these you keep in the refrigerator, but we'll get to that. Take these on a per need basis when you're coming down with one or all three of these. What to take. There's your quercetin, didn't talk about that. I've talked about that in other videos. Your vitamin D, zinc lozenge, NAC, 2 forms here. These are 2 forms I take. We'll elaborate on that in a second. Vitamin C and elderberry. I love it. We grow our own elderberries, but that's also liposomal, and I think that's very helpful. A little botanical medicine in there. Liposomal vitamin C, liposomal glutathione, and your electrolytes. This is what I keep on hand, what we keep on hand. These elderberries, gorgeous plant. We keep all these in the fridge, and you can always use these anytime if you want to. That's fine. There's not like the toxicity is super high. I've never reached it. And it's easy to fall in love with these. I was about to say, use these too much. We use these as a special occasion. You could use these every day if you want to as well. Vitamin D with K2 magnesium citrate for me. All right, know your levels. You want it to be between 40 and 60, ideally a little higher to reduce the risk of infection. It is recommended that people at risk for influenza and or COVID-19 consider taking 10,000 IUs of ID for a few weeks. So if you're really into that, by all means, but not on a regular dose. I take 5,000 IUs a day with K2 magnesium, and but that's your choice. So this is a little bit you being your own doctor. Do not blindly take vitamin D, but measure first. Know what levels you are. Don't be, oh, it's good, I'm going to take this, because people can OD, can do bad things to themselves by taking too much vitamin D. Make sure you are supporting adequate glutathione levels as previously covered in this video here, which was entitled, What You Haven't Been Told About Vitamin D Changes Everything, which is about glutathione deeply relative to what it does for your liver and vitamin D. What's in our medicine chest? We have all these things. And so these little numbers down here, I'm going to show you where you can order these if you want to at Fullscript, or at least you have your brands, ways to identify it. You get all these emails afterwards. Where do I get this? This is where you get it. I'll show you. But this is it. This is what we use. This is our A-team for protection against viral respiratory viruses. Anti-inflammatory, a little bit different now. People say, what do I use for anti-inflammatory instead of aspirin? What I would use is these 3, which have now become famous. They've been around for the last 20 years. They're proteases, a whole different mechanism. They break up proteins. They chew up proteins, if you will. And it really came out of the idea that if you had a digestive enzyme, and if you took a digestive enzyme while you're eating, it helps you digest. If you took a digestive enzyme on an empty stomach, it ends up being an anti-inflammatory. That observation was probably 50 or 60 years ago. It's obviously evolved. And now when you put together curcumin, bromelain, then you can choose, have a brand here, which is fine, a good brand. And there's a number of brands that are fine. And nattokinase, and I put nattokinase with suriptase, which is an enzyme from silkworms, also an anti-inflammatory. But these 3 together are considered a spike protein detox, often used for long COVID, and it's not a quick fix. It's something that goes on for months. And the idea that in 6 months you're much better, and years you should be covered by breaking down the inflammatory, the chronically high inflammatory biomarkers on an empty stomach, always. What's old is new again. So NAC is always being combined with something new. NAC and bromelain is called Bromac from Australian French. NAC became famous back in the 60s, as in 1960s. And it was known, first became known then as a antidote for Tylenol toxicity. And it came off label, so it means there's no patent on it anymore. And so nobody's really making any money. Anybody can make NAC other than a supplement. And a couple of times, because it was formerly a drug, it almost got banned from being a supplement. But now what they've done is that there's a number of companies that combine something with it. So bromelain, we just talked about, is a protease, put that together, and now they can put a patent on that. And you have Glynac, which is another one, which I don't think much of, from Baylor College of Medicine. A word about taking both. I think you can take both. I like to take this one. If you take too much vitamin NAC, and there's a lot of studies on NAC, I've done videos on it, you get a stomach burn. And once you get a stomach burn, you're really sensitive to it, so you really can't take much after that at all. So what I do is I mix it, I alternate with these 2, and they're fine. You can see what they have, and it works out for me. But I do take glutathione and NAC both. It's not like a redundancy or a little bit, there are, but NAC is a precursor of glutathione. It's also a mucolytic. It does a lot of other good things. So I do take both. So here's more on NAC. I've gone into that at length. It mentions NAC combinations like Glynac, which is supposed to be anti-aging. It's not anti-aging. Glycine is a precursor for glutathione. NAC is a precursor for glutathione. It says you put them together, you get more glutathione. I don't think there's any research to support that idea. It's back to the idea that NAC is so popular, connect something with it, and you now have your own product. It's not bad, but it's not like exceptionally good. Some liposomal companies go, you don't need NAC anymore. I disagree with that. I think you need both. However, liposomal glutathione is wonderful, and it is a shortcut, and it's only in the last couple of years have we had this available to the public. Before, it was only by IV. You had to go someplace and you got IV glutathione, and your life became better. How many people have access to IV therapy? Not many. And so therefore, liposomal is a wonderful aspect. So here's where you can get that. It's on Fullscript, and in the back of every video I do, there's a link that says just like this. This is from our courses and so on. But sign up or don't sign up. It doesn't cost you anything. I put these together as a COVID flu protocol. So you have all these things, so the dosage is there and everything. And you can read that right now. And that's how you get there. Say, in the very least, consider it. In the very least, consider buying these wherever you buy your supplements. Glutathione, it's your front line of firefighters, a long list of videos on glutathione should you want to know more. By the way, glutathione in a larger context, here's other research papers. Liposomal glutathione elevates body stores of glutathione. Yeah, and supports immune system. Right, and that was 2018. US, glutathione deficiency as the cause of pathogenesis in SARS-CoV-2, severe COVID disease. US, 2022. As much as I always say, there's not many US studies. Most of these are US. Here's one from Russia. Endogenous deficiency of glutathione, most likely cause of serious manifestations of death in COVID-19 patients, 2020. That's a profound study. Role of glutathione in prevention of COVID-19 immunothrombosis. Boom! A US review, 2023. Vitamin D in COVID-19, a review of the role of vitamin D, US, 2021. Potential role of glutathione antioxidant pathways in psychiatric disorders. A whole nother chapter I didn't go into, maybe a video in the future, but profound. So glutathione and NAC dosages, they're right here. For non-acute, I would do 100 to 200 milligrams 4 times a day if you feel you need it. You know, and you can, it's fine. I mean, you always need, so if you're one of these people that have one of these two situations, insulin resistance or a lot of SNPs there, and you know that, it's good. There's not a downside, there's certainly an upside. For acute, you go far higher, 1,000 to 2,000 milligrams throughout the day. NAC, 600 milligrams twice a day. Between meals, ideally on an empty stomach, the reason I mix it with this, meaning every other one, is because of the stomach burn. Okay, summary. Predisposition factors are insulin resistance and genomic mutations, HOMA-IR. Get tested, know your levels of glutathione, vitamin D, and omega-3. You got to know in the very least your IR status, right? Onset factors to address. All these things, this whole kit and caboodle is the protocol for me. This is what we use. We take it seriously. It does happen. We never got vaccinated. One of these things on this channel, I don't go into vaccination. That's the purpose of it's so invidious. You just mentioned that. It's like everybody argues with you. So I pull that out of it. I'm saying this is what you can do for yourself. Whatever you think about vaccines, it doesn't matter. This is what you can do for yourself. I try to take a different perspective on that. Okay, long COVID, the value of proteases. There you go. They're the products. Those are the dosages. That's why you would take it. So a word on half-life of supplements, which are really just the tip of the iceberg. It's important to know that. People who go nuts on vitamin D know that it has a half-life of 15 days. In other words, when you go too far, and it's easy to go too far, it can start breaking down your bones, it just doesn't go away in a day or two. It takes a long time for that to unwind. Whereas vitamin C, the reason you can really amp it up while you're feeling lousy, and it's a thing called mast cell stabilizer and does a lot of other good things, supports your adrenal glands and therefore your electrolytes there. It has a very short half-life, 10 to 12 hours. So your body bails it out very quickly. The only thing you could run into, if you're taking high dosage and then stop because you ran out or forgot or something, you can get into what they call rebound scurvy. That means you'll experience scurvy because your body keeps throwing out vitamin C even though you're not taking it anymore. So then you obviously normalize. But the half-life, glutathione's 90 minutes, 2 to 3 hours in the liver, which is pretty much the same thing. NAC is 5.5 hours. Omega-6, omega-3, fish oils, if you will, it's almost 2 days or day and a half. B12 is 6 days. Folate is 98 days. People get themselves in trouble with folate all the time. They go, I'll just take more folate and B12 because I have these SNPs. They have no idea their levels. And I've actually seen them come in. I go, and this now starts with other problems. All right, now you have your viral respiratory first aid kit. Hope this got you to thinking about taking action on yourself. The end. Till the next project. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics that you've seen that I've done in the past, then please let me know below in a comment. Till then.